my question is, ionizing radiation is, fill in the blanks, or blank is mutagen. Is it high, low, medium?
Low?
Okay. Low, that's the correct answer, yes. So as I briefly mentioned, how do we manage or minimize radiation dose? So when you look at the bigger picture, there are three things that you have to consider. One is occupational. That means the persons who are involved with getting the X-rays. And patients, right? Basically, occupational is operator, like a dental assistant, dental hygienist, dentist, in our scenario. Patients, those who are being exposed to certain amount of radiation, and public. So what do you understand by deterministic versus stochastic effects? Not next. Yeah, go ahead.
Seemingly random without any particular. At least that's what.
How about deterministic? No.
Wait, sorry, I didn't.
Okay. What is the difference between stochastic effects and deterministic effects? You can phone a friend if you want. I think not the next week, following week is exam, right? Midterm?
Is stochastic effects when it's random?
Mina.
Has something to do with the dose. Doesn't.
Can you a little more improvise on that?
So stochastic effects is an effect that you'll have either way without. It doesn't matter like if it's a high dose or low dose. So kind of what Megan was saying, kind of random, as opposed to deterministic, which is related to the amount of dose.
Yeah, the best way to remember is D, letter D, deterministic effect, and it is dose dependent. So as you increase the dose, there is effect on the body. Stochastic effects, all or none. So what we think is even one X-ray photon could cause cancer. So now, this is the slide that we have to look and identify what is this slide talking about. So this was way back done in 2009. So if you look at these stats, we do encounter certain amount of background radiation. Now, let's talk about what I mean by background radiation. You guys know anything about background radiation? Yes, right.
Well, there's cell phone towers that are pinging around. There's radio stations, not as much anymore, but certainly there's satellite, the sun. What's
Okay.
radiation? Yeah, there's radiation everywhere.
Okay, so we live in a world where we are exposed to radiation from different things. For example, did you guys purchase any house recently?
What?
Did you guys purchase a house recently? Yes, okay. When you purchase the house, did you check what is radon gas? Can you enlighten me a little more on that?
No, my husband did it. So.
Okay, that was easy.
I just know he did it.
Okay. So when you purchase a house, in certain areas, there is a radon gas that is being exposed. So it's a breakdown from the uranium, then polonium, okay, decay. You know, you might have learned in organic chemistry. So they will emit a gas, radon gas. And since we can't see, we can feel them, we may be ingesting those things. So it could cause lung cancer. So that's one of the reasons that when you purchase a house, they'll put big vent so that all radon will be exited. See, I'm giving you tips how to buy a house, other than radiology, right? Okay. So we would be exposed to radon. Okay? And when you are flying in an aeroplane, we are exposed to cosmic radiation, right? And if you are living in Denver, you'll be exposed to much more higher radiation. Anybody from Iran, there is an area, particular area, they will be much more exposed to radiation because of a lot of nuclear activities. And of course, we know about the USSR, former USSR, or Russia currently. So on average, this is the amount of radiation that is being getting, that was done in 1980 study. Now it has doubled, so that's like 6.2 microsieverts. And where is that? The extra radiation that is coming is from the medical radiography. For instance, do you want to dim the lights? So we do have a CT, we have a nuclear medicine, and radon is a very, very, very big thing. So the radiation or background radiation has almost doubled from 3 point to 6 point. So that means we have to take care now much more because we are getting more radiation or we are being exposed to more radiation. So this is a slide that basically talks about the various types of imaging modalities that are being done and what is the amount that is being contributed. So if you look at the dental, it's 2.5%. So we are not on the very high level, but we tend to take more radiographs, like every 6 months, biphasic, right? And pans, on occasion. We'll talk more about when we talk about how to prescribe the radiographs, when do you order a radiograph or prescribe a radiograph. So we have to take certain precautions. So one of that precaution that we take is a lot of consent. What I mean by that is as low as reasonably achievable. So that means if you don't need an imaging, then don't order or prescribe a radiograph. Okay? If you think clinically this particular imaging is sufficient, for instance, bipins are sufficient, don't order full mammographs. Okay? For instance, you could get the panoramic radiograph, which we are going to talk maybe a little later, and then you can order pan and full mouth series. That should be sufficient for most of our dental works. But if you are going to place an implant, yes, then you have to order a CBCT scan because you want to look three-dimensional. Okay? But just because you bought a brand new machine in the office, don't try to get on the CBCT scan on each and every patient because you are exposing them to more radiation. So what are the things that we can do to minimize the radiation? One is awareness. That's exactly what I'm doing, trying to educate you guys, right? Avoidance, meaning to say that if you stay away from that radiation, far, far, far away, then you will not be exposed to radiation or minimal effects. Time. As the time goes, the decay process will be reduced and you will not have much effect on your bodies. And distance, of course, you have to maintain the distance. And shielding. What are the other things that we could use to prevent? For instance, like we talked about alpha particles, like beta, gamma, or gamma particles, right? So for gamma particles, what is the thing that you want to use? Louder, yes.
Concrete.
For alpha particles?
Paper.
Paper, very good. Now, how about X-rays, dental X-rays? That's what we are going to talk now. Okay? So, NCRP, this is the body that prepares or gives the guidelines or recommendations how much a person or a patient can get exposed to a certain amount of radiation. For instance, is maximum permissible dose is 50 millisieverts or also 5 gram. That's the maximum dose a person can take. And for the eyes, it's 150 millisieverts. Again, this is very, very, very important, these numbers. You have to memorize, sorry, there's no other way. And then, not so much for my exam, but for your boards. Inevitably, they are going to ask you. Yes.
Is this per dose or per year?
Per year.
Per year.
Yes. So, and rest of the body is 50 rand. So what is the maximum dose for occupational thing? Like for us, you could calculate it by 10 millisieverts multiplied by the age. And for 18 years old, they are same as for the public. Now, what are the other things that you can do? One is justify. We just briefly talked about justification. So, can you order all radiographs, all imaging modalities for the one particular patient? The answer is no. You have to justify what is the cost-benefit ratio. Okay? For instance, you want to diagnose a pathology, like a dental case. You could use biprines or full-mouth series. That's more than sufficient. You don't need a CBCT scan or CT scan. It's too much, right? That's where the justification comes. And you optimize with less exposure, like for example, using collimators, right? We talked about collimators. Limiting the dose, again, we can use various sensors, like if you're using film, your digital sensor, it could go down all the way from very high dose to low dose. And of course, LRA principle. So, for now, don't pay too much of attention to this particular slide, but when we talk about prescribing the radiographs, this is what we'll discuss in detail. When a new patient comes, what we have to do. When a recall patient comes to your office, how do you prescribe, or what are the things that you need to prescribe? So for the public, right, it is 5 millisieverts for the whole body per year. Lens, it's 50. If you remember, for occupational, it's always a little higher compared to the public. And if the patient, dental assistant, is a female patient and she comes to your office and she says she's pregnant, then how do you analyze from there? After she does pregnancy, from that month you have multiplied, this is 0.5 millisieverts per month after they declare pregnancy. Okay? That's the maximum dose. And other things what we could do, patient selection, meaning to say that for example, a chubbier patient versus thinner patient. So for chubbier patient, you may have to increase the dose, right? Why? More tissue, right? And of course, we briefly touched on exam, the different types of imaging equipment that is available, and we'll go little details into personal protection. Also, we briefly touched a few things. Again, we are going to revisit, like collimator, filter, LED ekrans, etc. So now, those who are using films, they could be numbers, okay, like a D, E, F, okay, and K. If you use the F-speed film, that means it's very, very good, so it takes a lot less radiation, so you can minimize the radiation. If you go and visit any dental office who has been practicing for a number of years, say for instance like 50 years and plus, they love D-speed films. If you go and tell them 100 times also, like please use F-speed film or digital, they won't say no, because I love digital. D-speed. Because their eyes are used to looking at the D-speed films. The downside is more radiation. And using rectangular collimator. Some of you guys who came to lab, they may have seen how to use a collimator. Collimator is nothing but a plastic device that you insert the end of the round collimator. That's the X-ray tube head. Okay. Just by putting that plastic, you're reducing the dose by 2/3. So why can't we do that? And if you're using extramoral films, then we have to use something called as rare earth springs. So nobody is using that, but for your boards, it's very, very important. They may ask you, if you're using extraoral films, what is the thing that you have to do to reduce dose? Then the answer should be rare earth springs. So NCRB recommends that if you use all the precautions like digital X-rays, right, and reducing the doses, and if you're following all the protocols, Radicron is not required. However, certain states, conservative states, like our state, Ohio, irrespective of whatever NCRP says, they mandate that Radicron is required. So depending on your state law, it could vary. For instance, Florida, look, those who are from Florida, they can say that, okay, they don't have to use lead acrylics. Again, it's a state law. So patient protection. I have highlighted in red, patients should not hold the films or tube head during the exposure. If I walk, even today, in spite of telling and putting that in red, students will be telling patients to hold the tube head. So what should I do? Disha, what should I do for that? What is the consequence? They should have some consequence, right?
You're asking me to.
Yeah. So that we can make a policy.
I don't know, tell them, like, catch them when they do it, and then, or like take a
I have
picture.
pictures.
Yeah, okay, then put it on PowerPoint and then show it to them.
That's exactly what I did in the past. And then take them out of the clinic, yes. So please, don't make me a bad person, okay? It's on you guys now. If I see somebody requesting to hold the tube head or the film, you'll be in big trouble. Okay. Now, why this is such a big deal? Why? Why do I care?
Maybe it puts the dental office in an actual position.
So as soon as you hold your fingers like this, fingers are being exposed to radiation. So is it really required? So based on a lot of principle, the whole principle is that you have to minimize the radiation. And then what else? When you're pressing the button, you may have seen in clinic A and B, there is a lead glass, right? You have to always see the patient before you press on, while you're pressing the button. The reason is because when you're pressing and you're talking to your friend, what if the patient does like this? You'll get a big cone cut, right? always observe the patient while performing the procedure. And use thyroid shield or collar to reduce the dose. And collimator. So this is how a end of the tube head will look like, round, and we have inserted a black plastic. It's from a company called RINN, R-I-N-N. There's one more. So the whole idea is you are restricting the beam. Just by putting the plastic, you are reducing the dose by 2/3. And why do we do that? The other thing is because it reduces the scatter, you'll get a prettier images, right? And we do have something called as XCP instruments, which we talked in your first class, and some of you may have used in the lab. It's by using these XCP instruments, you are aligning properly in the patient's mind. Minimum chances for an error. So now, these are manufacturer who, when he is designing before FDA approves. FDA is, you guys are aware of FDA, right? I don't have to go into details, okay. So they mandate that if we are using anything below 50, then they have to put aluminum of 0.5. If it's 50 to 70, this is what our range is. They have to insert 1.5 millimeters of aluminum because it can absorb low dose or low energy photons. Generally, we don't use more than 70 in our dental radiography, specifically intraoral radiography. But if you are using CBCT scans, then it's a different story. So again, this is a very important question for your boards.
Oh, that's exciting.
Yes.
Where is the aluminum inserted?
So there are at various places they place an aluminum before it emits. Like, remember the X-ray tube head?
Yeah.
Cathode, anode, from there it comes. And there, exactly after the beryllium, they place aluminum. Because they, low energy photons, they don't have a lot of energy to penetrate and give a good image. So what they do is, they'll absorb low energy photons. Yes?
Does it resorb or reflect them? Because like would the reflection damage the machine over time if it's constantly giving radiation?
No, because it is absorbing only low energy photons. For instance, I'm going to use a weird example here, or analogy, right? When you applied for a dental school here, the DAT score is supposed to be something like 20, right? Anything less than that, our dental school will not accept. Why?
Too low.
Because probably they may not perform very well. So that means technically, again, I'm going to use this word just so that you'll understand. They may not do very well in their courses, so they don't want to take any chances. Similarly, what they do here is they put aluminum so that all low energy photons are being absorbed. It's not going to strike the patient's skin. So we want a very high quality. All that scores of 22, 23, because they can ace. When I say ace, here is getting a good image quality. Yes? You had a question?
Yeah.
Okay.
So in our X-ray, do we have a filtration of 2.5?
Yes. So that's manufacturer does that. We don't do anything.
Okay,
So before they come into the market, they put aluminum before they release into the market, and FDA checks that. Anybody who is fond of watching Dr. Oz program? Nobody? Sometimes, okay. Or if you're familiar with this picture. So you're not a big fan of Oz.
Not big enough, I guess.
Okay. when we talk about panoramic radiography, we'll go into a little more details, but please remember, this is a thyroid collar that was asked to wear. If you watch his show, sometime back, way back, like 4 or 5 years ago, he suggested that every patient who is getting a panoramic radiograph should be protected with thyroid collar. If you use thyroid collar, and this is what the resultant image will be. So that means you are losing the diagnostic thing. That means you are exposing one more image to get a diagnostic. So ideally, no thyroid collars for PAN, but you have to use the other lead probe. Make sense? So big no for Dr. Oz. And when you are using the tube head, back in days when I was practicing, way back, we used to have the X-ray tube head. It's pointed like this. They thought X-rays were coming from a point. Then they realized, no, they changed to wrong. Now, after that, what they said was, if the tube head is smaller or big, larger, like, which one is good? The analogy that I would like to use here is, if it's like a smaller tube head, the traffic from India and China, because as soon as they come out of the tube head, they will react with the air and they can deflect. Whereas with the long tube head, you are aligning them to go and then hit the body only in certain region. You're not exposing it to all the way to the extra regions or unwanted regions. So now, what are other precautions as an operator that you could do or shield yourself from the radiation? This is pretty good only for dental radiography. Okay? So imagine this is the tube head and the X-rays are coming. The safest place to stand is 90 to 135 degree at an angle. Okay. If you stand here, you'll get the back scatter. Also here, some scatter, not in this region. And how far you should be standing is 6 feet. After 6 feet, what is going to happen is they don't have enough energy to penetrate the skin. So that means, imagine, or the analogy that I would like to use here is like, when you have a snow flurries, what is going to happen? It's going to touch your skin and fall off, right? It's pretty similarly, because they don't have a lot of energy. So, technique. So we do have certain guidelines that we use, or the standard ones that we recommend to use. For instance, for upper anteriors, the kV that we use is 63, and the MA is standard. That means it's fixed, 8. You could change the time. And if you have a healthier patient, then you may want to change the patient time to a little more so that the X-rays can penetrate more and you'll get a pretty good image. If the patient is skinny, then you have to reduce the time. Because in this, the machines that we have, MA is constant or fixed. You can't alter. So let me ask you this question. If you have MA 8, 9, and 10 option on your X-ray unit, which one do you or would you prefer to keep it on? 8 or 9 or 10? And if so, why? And if so, if you believe the salesperson, whatever he says, then I'm not going to ask you to answer this question. How many of you want to believe salesperson rather than me? Everybody? Okay, that's fine. 8, 9, 10, which one? Nobody?
I
I don't understand the question.
Okay, so you don't understand the question, okay. So there are three options that are available on your X-ray unit that you can, on X-ray unit or control panel, that you could modify or alter MA. You have option of 8, you have the option of choosing 9, you have option of choosing 10. Which one do you prefer to use?
According to OR, would it be the lowest that you need? Would 8 work?
10,
Then why?
because you told us in the first lesson. Why?
Okay, you listened partially to my class. Okay, good. Can you improvise? Yes.
Higher MA will result in a darker image, so it'll be more contrast.
That's true, but I'm asking in slightly different fashion. Yes, Ron?
So higher MA will release more photons, so you will have a clear image
And why do you want to do that?
to get more not density, better
That's
density.
true. Little more. Can you improvise on that? I know you guys, whatever you guys mentioned is correct, but I'm looking for something else apart from that. So if you use higher MA, like 10 MA in this particular example that I mentioned, is because sometimes patients move, right? So if you're releasing higher or more number of photons with less time, you have more penetrability, and then you'll get an image so that you don't have to wait too long. Because, say for example, 1 second versus 2 seconds. I know it sounds ridiculous, 1 or 2 seconds, but when you're dealing or working on a patient, what if they do like this when you're pressing the button? Right? How much? Millisecond? So it does make a lot of difference. So always when you're using an X-ray unit, keep at the highest MA, and then you can alter the time. Okay, make sense? So this is the picture that is describing when we started off with the films. You can see the radiation to the patient in 1999 was the highest, right? What are the improvements that we did along the way? We started with A, B, C, D films, and then we reached all the way to F, right? And then we stopped. And then later on, we moved on to digital imaging. So you can see the amount of dose patient is getting very, very, very less. And that's one of the reasons dentists don't care about radiation in general, like using the collimators, right? You could still use collimators and still reduce 2/3 of whatever you're releasing. Make sense?
So
Yes.
percent on the y-axis means
It's the dose here,
exposure or dose.
and the number of years that the various developments have happened from A to all the way to F and digital imaging.
Like those of X-ray.
Yes. Or the patient that is getting amount of radiation when the X-ray is hitting. What else we can do? Barrier protection. Like, not so much in our instance, because since if you can stand like 6 feet away and 90 to 135 degrees, we don't need any barriers, right? However, if you are using D-speed, then it's a different story. Then you have to stand behind the lead wall, then you have to see through the glass. Okay? And never stand in the way of primary beam, because you'll get a scattered radiation. So imagine this is the patient's head, in tube head, and if you stand behind exactly, you'll be still exposed, because the X-rays could traverse through the body and interact with the person who is standing behind. Okay? Use the fastest film, like F or digital images, or digital image receptor, sorry. Do not hold films for the patient. I told you, patients cannot hold the films. Even as an operator, please don't hold the films. And there may be a certain situation that you may have to help the patient. Then somebody who is accompanying the patient, you would ask them to hold the films, because public, their radiation exposure will be way, way less compared to the outpatient. Make sense? And of course, quality assurance procedures like taking them out of the clinic, right? If I see holding them, it's nothing but quality assurance, right? If they're not following the protocols.
I have a question.
Yes.
So if there's, for some reason, someone has to hold the film, like there's missing this, or the patient has missing teeth, then it would be better to have someone accompanying them hold the film than the patient themselves?
Yes.
And why is that?
Why is that? Is because patient is getting some amount of dose, and the patient's accompanying may or not have, or may not have got the radiation for that particular year. So you could ask them to hold the film for that. Whereas you can't hold because you may have taken on that particular day 10 extra radiographs. So you may have got enough dose for that particular dose dependent. So you want to avoid ALARA, using the ALARA principle. Make sense?
And what would we do if the patient didn't have anyone accompanying them?
Then it's a huge problem. Then our dental assistants would come and help. Yeah, always try not to, you guys don't intervene there or don't put your hands there. Because you'll be taking X number of radiographs. Yes?
Would you put a lead apron on that person?
Yes, of course. So I skipped one or two slides. Basically, if you understand this slide, it's nothing but the information that you can get from the previous slide. So imagine you are using a flashlight here. As the distance increases, the intensity will become less. Pretty similarly with the radiation. If it's like, if you are standing away to a certain distance, the amount of radiation dose or the intensity of radiation will be reduced. So that's why we asked you to stand 6 feet away. What are the other things that you want to do? Like, imagine you finish your DMD or some other specialty program or just DMD and you go to practice, buy a practice and you'll start practicing. You need to have written protocols for that particular office. What are the things that you want to include? For instance, if the patient, dental assistant is pregnant, how do you deal with that? Okay. What kind of sensors do you want to use? What kind of imaging modality that you want to use? And as I mentioned earlier, like we have to follow the protocol of time, distance, and shielding. Very important thing that I would like to highlight on this particular slide is, if I ask you, for diagnostic purposes, is there any limit that you can limit radiation to a patient? Yes or no? The question is there any limit of radiation dose to a patient if you're checking or if you want to diagnose something? No, because its answer is there on the slide. Can you explain me why? Because you have to see the risks and benefits, right? What are the risks and what are the benefits? So risk is low if you're doing some radiographic exam. And the benefit is, okay, we are able to diagnose, we are able to treat this patient, yes. You would weigh the cost and benefit ratio. So this is kind of counterintuitive to whatever I discussed earlier, but for diagnosis, yes, you could go to any number of X-rays if it is pertinent or if it is required. Okay. So, what else you could do is if somebody asks in your dental office that they are scared of radiation and they want to check how much they are being exposed, then by law you have to provide badges to them. So those badges basically record the dose the patient is getting. So the basic and the most easiest or the cheapest one is film badges. So basically they'll put on something like this. So depending on the imaging modality that they are doing, for example, fluoroscopy, they put more legs are being exposed. So they'll put the badge here. If they're doing something with their hands, then they can get their rings. Okay? Or to the whole body. And now you could ask, why is that I'm not wearing any badge? Right? I don't have any badge, but I work in radiology, right? Because we know that we take enough safety precautions, and we do have badges that monitor our area. And generally with the dental radiography, we don't need badges. But if somebody asks, you have to provide in your dental plans. A slightly enhanced one is TLB. Again, it's pretty similar. They absorb the radiation and they'll spit out some information. Can be given to the person or occupational operator that who is working on taking your X-rays in your dental office. So when you're talking to a patient, always you have to discuss what is the risk, what is the benefit. Okay. If you take a panoramic radiograph, this is what I could see. Like for example, third molar could see visualize. Okay, because you came from with a third molar. Like with the periapical radiograph, I may not be able to capture the third molar. And you could use background radiation when you are comparing what kind of dose the patient is getting. So for instance, if you use these comparisons, smoking a pack of cigarettes a day, they could lose their life by 6 years. They could say it's much better than smoking a cigarette. You could get as well a pack. You know, you could use those kind of analogies. So the important thing from this particular slide is, as we get older, and since we are living in this world, we are exposed to different kinds of background radiations, and inevitably we'll be getting a cancer at least 40%. Sorry, as we get older. So from birth to 70 or older, 40%. So on top of this, we have to take into other considerations like deterministic effects. Like how many X-rays they are getting, right? What kind of X-rays they are getting. So in California, those who are going to go back and practice in California, they have to give the information stating, okay, this person, like for example, John, took a pan and this person got radiation dose of, say for example, 2 millisieverts. They have to give in return, because they want to follow how much each patient is getting. So fortunately in our state we don't have that law yet, but it's coming. What other things that you could use are for comparison purposes? The things that I really like from this slide is, say for instance, if you are eating 1,000 bananas, you could die from cancer that's radioactive potassium, okay? And those who love Denver, if they live in Denver, they could get cancer because they are living at a higher altitude and they are exposed to cosmic radiation. And if you're traveling by car 230 miles, you could end up getting an accident. Okay? Scary, right? But facts. How about this one? The other one is my favorite, this one. Drinking Miami water for a year. They could die from chloroform. Okay? Hey, these are not made up facts. I am not telling, okay? Okay, of course I am telling from this. Okay. So you could use those things for comparison purposes. Say, okay, this is much better than traveling 230 miles by car. Okay. The other thing is fetal dose or fetal risk from the dental radiography. Very, very, very important thing, right? So you could ask me a question like, this dental radiography has been in place for a number of years, more than 100 years, right? Is there a direct correlation with a dental radiography, and can it cause birth defects? Is there a correlation? Yes, no?
Between dental or just any radiation?
Dental only. Let's focus only on dental.
I don't think so.
Why?
Well, we were talking about the scatter. I would think it'd be I mean, I don't know, if you have an apron, it's probably a nice thing, but I don't know that it's necessary.
That's 100% perfect answer. Yes. So let's see what else I have here. I think I may have, yeah. Practical question. If a pregnant patient comes to your office and says that I'm pregnant, okay? What do you do? Andrea?
I will.
Send it to Puerto Rico?
I will tell that there's no risk for the baby because the radiation dose is pretty low. And
How much is Damo? Okay. So it is, going back to the question that I asked Brian, is can you distinguish a background radiation from dental radiography? The answer is no, because it's such a low radiation, it's almost impossible for us to distinguish between background and dental radiography. So that's why we don't have a lot of studies to authenticate, okay, can dental radiography cause birth defects? The answer is no, because it's such a low, we are exposed to different kinds of radiation. And virtually impossible for us to distinguish between those two. FDA and ADA has recommended that it's safe to get dental x-rays. Pregnancy is not a contraindication. And somebody asked me last time, can you provide me the links? Yes. Not one, not two, but 3 links. Enjoy reading, okay? So, yes, pregnancy is not a contraindication. So if you don't trust my words, please look at those 3 websites. And if you want more, there are a few more that are coming at the end of this lecture. What is the absorbed dose, right? Again, going back to my same version or repetition, fetal dose has no practical importance in dental radiography because it's almost impossible to distinguish and no risk to the fetus. And they cannot produce any birth defects. So always you have to weigh the risks versus benefits. So if I order this particular image, what is the benefit? If I order this, what is the benefit? Or can I just do clinical exam? More than sufficient. Okay, so these are the websites. Happy reading, okay? More information. If those who don't like to listen to my thing or they don't trust my whatever things that I said about fetus or pregnancy, please read this. You've got tons of information on these websites. 2 minutes break? Yeah. Midterm exam, right? Not the next week, following week you'll be taking exam. Anything that you want to know? Other than questions, what will be appearing on exam? So I think it's nothing to discuss, right? Nobody is asking any questions.
What's the format? Is it multiple choice?
It is going to be multiple choice. 30 questions.
Are there pictures?
Pictures. What else do you expect from radiology? So for instance, if you go to a photography session, or learning about photography, and what do you expect on your exam?
Well, a lot of the stuff that we've learned are values to have memorized, for example, yearly exposure, what is contrast.
Contrast and all those
what
things,
animate.
okay, so...
So there's a lot of that stuff. I don't,
When I'm talking about digital imaging, during your final, that's where I will ask those questions, not now. But now you got a little foundation. So chunk of questions from radiographic anatomy. Chunk, a big chunk.
like where are the condyles kind of questions?
Yes, something similar. Yes.
Here on the campus, the modules.
Yes.
The first module
So it's not working.
on the first day.
Is working or not working?
Module 2 and 3 are not.
Everything should work. Somebody, Rama?
It's not working. I thought you were working on that. 'Cause last time I did it work in class.
That's gonna be it. Okay.
Everyone gets an A.
Let me rephrase that. Most of them they get A. Yes. They have to put little efforts, right? This one. So it's like, for example, radiology is so simple that it's something like this. I'll give you an example. If I ask, if I give you a picture, I'll ask you to identify what animal is that. I'll say that animal has got white and black lines. Come on, guys. Black and white color on that particular animal.
Oh, penguin would work too. Yeah.
So they're gonna be
Zebra.
questions that.
The differential diagnosis could be Honda, right?
Oh, yeah, panda would work.
Yeah.
So we're definitely not gonna know the answer.
So something like that. Okay. Okay, 30 questions, all multiple choice questions, and you will have like 1 hour time, so 8 and 9, between 8 and 9, that's the time. And by any chance, if I'm not able to complete any portion, we'll reconvene here, same place. 9 to 10, we'll try to finish the portion. I know you hate me to the core, that's okay. I have to do my job of finishing the course. And at the same time, it's my job to make sure that you understand the topics, right? Well, shifting our gears from midterm to PAN, where the chunk of questions will be coming from, okay? So let's look at this particular example. This is a typical panoramic radiograph. This is how it looks like. Okay. Now, what do you see from this image? Anything? Yeah, go ahead. Your name, please.
Robbie.
Robbie. Yes.
Periodontitis.
Periodontitis. Oh my God. Did you see that?
No, whatever the
Okay. Go ahead. Yes. Periodontitis. Yeah. Anything else?
This is wisdom teeth.
Wisdom teeth. Anything else?
ERE.
Somebody said very interesting thing.
I think it's the earring.
Yes, I am more interested in earring, not about all other things that you mentioned. Okay. So now, let's take a look at the earring. Okay? This person is wearing a earring here. Now when? What do you think is this? Because I'm a dentist, I don't care what is happening in the maxillary sinus, right?
What's at the other ear?
It's like almonds.
That's exactly what we are going to talk about. What the hell is that? Okay? So at the end of the lecture, you are going to understand what exactly do I mean by that, what is the thing, and you are going to answer that, okay? So what are the objectives? So applications where the panoramic radiograph is being used, what are the advantages, disadvantages, and identify the normal anatomy, and production of real images, double images, and ghost images. So basically, panoramic radiograph is like our face is something like this, right? When you take an image, you get something like this, right? That's exactly what we are trying to achieve with the pan, right? So you're basically, when you're doing like an X-ray imaging modality, especially in this region, there will be certain amount of distortion or magnification that you are going to see, because that's where the curvature of the jaw is going to happen. So what exactly do I mean by tomography? It's nothing but a slices where you think you have a loaf of bread, you'll try to slice them and combine together. That's exactly is tomograph or tomography imaging modality. Like this one. Panorama. How many of you have got iPhone? They have a panoramic mode, right? What do you mean by that? What is this guy talking? He talks about houses, radon, and panorama, other than radiology. Come on. You just purchased an iPhone without knowing what is panorama? I don't believe that. Come on, guys.
You can capture parts of the view that would traditionally be in the image.
Yes, unobstructed view or wider angle view, right? Is nothing but pan. That's what you're trying to achieve. So you're going to get an obstructed view of the jaws. So where could we use this one? Evaluation from if there is a fracture or third molars, or if there is a large lesion, or if the patient is unable to do those intraoral radiographs in the oral cavity, then you could get a pan or bite wings, pan bite wings. And for surgical procedures, what are some of the advantages? Advantages are well tolerated by patient, minimal exposure time, and you do get a broad coverage. That's panorama, right? Relatively low dose to the patient. Useful for patient education. It does not mean that you want to learn something, so you get the patient and then try to expose. No, the answer is no. Disadvantages. Some disadvantages are, as I told you guys, because you are taking a panoramic view, especially in this region, there will be some distortion happening. So, this is also a technique sensitive. So if you don't place the patient properly in the imaging, panoramic imaging, then you would get either magnification or minification. So basically, if you look at this skull, and this is the X-ray source, and this is where the image is being captured, they will go in opposite direction like this. So for instance, like, imagine this is pen, right? So if you're going to rotate, so one will be going in this direction, the other one will be in opposite direction like this. So you're going to capture the whole view of the jaws. So when it's moving, so you're going to get a little bit of condyles, and then you're going to get molar teeth, and then premolars, and centrals and premolars, and then the other side of the mandible, and this is how it's going to capture. So it's by slices. So we will talk a little bit about what I mean by focal drop. So before a manufacturer makes, this is something they designed, they looked at 1,000 people or maybe 4,000 people, and they came up with a jaw size. So as I told briefly or mentioned earlier, it's a very technique sensitive. So if you don't place the jaws in that focal drop or within that image, then what is going to happen is you're going to see magnification or minification. This is highly, highly technique sensitive. Especially if you're using older machines. Brand new machines, they have come up with much more advancements. They are pretty good now. As I briefly mentioned, this is technique sensitive. So let's look at some examples, especially when the patient is biting in the anterior region here. This is where the patient will be biting on a bite block. So they have a plastic guide, they will bite here. And if the patient is not biting properly, I do have some more examples where you'll go into much more details, then you will understand. If the patient is not biting properly, then you could get minification or magnification. And these are brand new machines where you could increase the width. So even if you mess like 1 or 2 millimeters, still you can get a good image. So this is how a control panel of a shape machine looks like. So here basically you would select the jaw sizes, small or medium size jaws. And you're going to use these guides to help the patient to stabilize the head of the patient. So this is how a typical image layer will look like, or this is how the pan will look like. Look at this compared to the previous image. Something is wrong, right? So to get a pretty good images, what we have to do is we have to educate the patient. How do you educate? Ask them to remove all the removable appliances. If they're wearing partial dentures, you would ask them to take it out. No jewelry, no earrings. Okay? And of course, you have to disinfect the machine as you'll place a new bite stick. So this is with the edentulous jaws, where you could see that the patient's jaws are looking pretty good, and you can see the condyles. Nice pan. Or let's say it's pretty decent one. What else you could suggest? I ask the patient to stand straight, and neck should be extended. If the patient's neck is not extended like this, then what is going to happen is the cervical vertebrae, there will be superimposition of that, and it's going to mess up your image. So you have to ask them to extend the neck. And of course you have to use those guidelines, Frankfurt horizontal line. So these are the guidelines to place a patient properly. Like midline, you would check, and this line should be parallel to the floor. So ideal position, this is how it should look like when you're placing. Pretty good image. What is going to happen if the patient is positioned forward? And if it's too far back? We'll go into the details a little bit later. This is how it's going to appear. And if the patient head is rotated to one side, you're going to end up getting remember I told you earlier the bite block here. This is the bite block. You can see the incisors. It is way inside. Compare this one. This is way outside. That's one is ideal. So let's take an example here. My coffee. My phone. What else I could use? Maybe this one. Yeah. So imagine this is the patient head, and this is the X-ray source, and this is where the image receptor or image is being captured. So we need to maintain, like, say for example, just to give you an analogy, like 5 millimeters and 5 millimeters should be equidistant. So if the patient's head is closer to the X-ray source, like this, then you are going to get magnification of teeth. So if it is the other way around, like this, closer to the receptor, then you are going to see magnification. So that's why it is pretty technique sensitive. So some examples like here, if the patient's chin is down, like this one, you have to ask the patient to bite on the bite block, right? What if the patient does like this? Then you will get something like this. What if the patient does the opposite, like this? You are going to get this square face. Can you see the difference? So you should know how the images are appearing, and based on that you can say, okay, this is the problem. Then you are going to rectify that problem to get a pretty good image. So if the patient is rotated to one side, meaning to say, like, you would ask the patient to bite on the bite block, like in the center, right, this one, right? Then you will get perfect. What if I do something like this, but biting on the bite block?
Teeth over each other.
Say one more time.
You get the overlapping of teeth.
And what else?
Some will be magnified and some will be minimized.
You got the concept. I was about to demonstrate. I don't think do I need to demonstrate? You good? Wonderful. You guys are smart, so wonderful. So here you can see the magnification of the teeth. Here, not so much, because the patient's jaw is rotated to one side. One more example. So let's talk about the double and single images and ghost images. Real images, very important. Where the object is located, that's very, very critical. If it's between the center of rotation and the film or the image receptor, then you are going to see real images. What are the real images? Some real images that you could see, and some double images, or like, for example, hyoid bone, epiglottis, hard palate, soft palate, because they are in the midline, and the structures that are lying in this red zone, that's where you're going to see double images. For instance, like here, this is a part of hyoid bone, part of hyoid bone. There is only one hyoid bone, right? You guys learned in anatomy. No? But you are seeing two, because it's double image, because it's lying in the midline, it's like splitting. How many hard palates do you have? What the hell is asking, right? One, but we are seeing two here. This one is the hard palate. The top line that you are seeing is the ghost image of the hard palate. And here is an example of epiglottis here. Again, it's a double image. vertebral column. We have only one vertebral column, but you're going to see two, especially if the patient is smaller in size, you're going to see two. Yes?
So, so you just see like one image on either side.
That is correct. So, how does a double image will appear? If the structures are located between panoramic rotational center and their center, basically, if you go back here, if you see something like this object, then you are going to see the double images happening. The ghost image is formed from, if it's between source. So when I say source, is X-ray source and the center of rotation. Then you are going to see a ghost image. For example, like what we saw, like earring, right? So the patient is wearing a earring, so it will be projected higher up and it will be horizontally magnified. And letters like here, L, is projected higher up and this is horizontally magnified. Letter R basically is this one. So the ghost images, remember, they will be higher up compared to the normal one and they will be horizontally magnified. So now you know what you saw right there, earring on top. That's the ghost image of the earring. Now you could ask me, why the hell I care about earrings, right? What if they are falling in place of your diagnostic region? For instance, like this one. You want to see the apical region of this molar. Number 2. It's blocking your view. So then again you have to ask the patient to get one more pen because you want to do diagnosis of that particular case. So rather you would ask them to take out earrings and get it back. What else you could see? This is a part of mandible and also this is a part of mandible here. So this part of the mandible here is projected higher up and opposite side. This part of the mandible is projected higher up and opposite side. So and letter R, this is what it is. So what is the summary? Those images, they will be lying opposite side, higher up, horizontally magnified. And they will be blurred images. Something that I wanted to let you know is, especially if you are doing with implants, this is very critical that you understand how the X-rays are being projected. So we talked about intraoral radiography, right? So for bipings, you would make it like straight on, you'll get the biping images. With the maxillary teeth, you may give a slight angulation, mandible slight angulation, or more or less parallel, right? Whereas here with the pan, the X-rays are coming at an angle from behind the patient, and they are going higher up like this. So it's like this. So what is the disadvantage? Is the structures that are on the lingual aspect, they will be projected higher up compared to the buccal aspect. So what is it? Let's talk about a clinical scenario. If you have a buccal and lingual cortical plate, like this, and the X-rays are coming from behind, since this is closer to the X-ray source, it may mimic on your pan like this. You'll think there is enough bone on the lingual aspect. In actuality, there is nothing, or less bone compared to the buccal aspect, because the way the X-rays are being projected higher. So that's why we recommend the 3D imaging modalities such as CBCT scans when you're doing an implant procedure, because you can see the level of the bone appropriate.
Dr. Syed,
Yes?
are there certain settings you can adjust that make the foreground more vivid and then the projected image in the back less so?
No. Unfortunately, with the pans, that's the setup that is they've come up with. They try to do a lot more things. No. I thought this is where we will take break, but since we already took break, we will continue. What else we could see on the pans? We could see dorsum of the tongue, soft palate, lips, and mesiolabial fold. For instance, what is this? Louder, please. It could be wrong.
Tongue.
Loud, loud, loud.
Tongue.
Tongue. No.
Is that the opening to the throat?
Opening to the throat, no. I love those guys. Come on, guys. Patel, right? No? Sorry. Lips. So you know the answer. Yes, the patient did not close the lips properly. So it's like this. When they are. So when you ask the patient sometimes to close the lips, they don't close, right? That's exactly what it is. So they did not close the lips. Yes. So a few things. This is the floor of the maxillary sinus here. This is the zygoma. You should be knowing, right? What is zygoma? Yes, wonderful. Nasal septum here. Lateral wall of the nose. And then this becomes the anterior wall of the maxillary sinus, and all the way up to here. Yeah. So you can see something black, right? This area. If you suspect or see something like that, black area, it's not a good thing, because it's not of a diagnostic image, because you cannot see anything. So let me ask you, since you are experts in the imaging right now, right? You know the physics behind everything. Why the black is there? What is happening? How the X-rays will react to the different tissues? How the X-rays will travel if it's air? Black. Who said that? Name. Ben? Did you say that?
I said.
Okay. Can you enlighten a little more on that? Because there is nothing to absorb, the X-rays will pass through. Right?
Yeah.
If there is a soft tissue like tongue, it's going to absorb. If there is a bone, it's going to absorb. If there are teeth, then it's going to absorb. If there is nothing, then it's going to travel. Like for instance, in maxillary sinus is filled with air, so that means X-rays will pass through. So here, as you can see, this part, maxillary sinus is black. That's the normal presentation, right? So what do you see between palate and tongue? Yes. If the patient is not placing the tongue to the roof of the palate like this, then you're going to, if it's the patient is holding like this one, the X-rays will pass through, and then you end up getting that black region. That's called as palatoglossal airspace. like this one. So what do you ask the patient to do? Hold the tongue to the roof, the palate. Okay, so that X-rays can, the tongue can absorb the X-rays and it becomes more diagnostic. Okay, and since this is even extending this airspace, it's between tongue and the pharyngeal area, so this is called as glossopharyngeal airspace. So after you take a pan, how do you interpret or do the interpretation? There are a number of ways of doing the interpretation. The way I would recommend you guys to do is start from the condyle like this one, and then the coronoid process, maxillary sinus, and the nasal fossa region, maxillary sinus, and then coronoid process and the condyle, and then you drop down all the way here, look at the cervical spine as well as the ramus. And then when you are going down here, you could see there is some kind of step-like discrepancy, right? The mandible, the angle. So that step-like discrepancy, what you're seeing is nothing but a fracture. So that's why you should evaluate thoroughly each and every part. And when you follow, again, the inferior border, look at this. There is a fracture again, one more fracture line. Okay? And then you look at this region, look for this region, especially in this region, for any calcifications. And then you would look at the ascending ramus. And then teeth 1 to 16, 17 to 32. So with that, you will be completing your panoramic interpretation. So just to give you a little more graphical presentation is something like this. And then like this. And then like this, then up here, and then teeth. One question is always fine. More than that, it's a problem. Yes.
What's the purpose of checking classification?
So, just for now, there will be, okay. You guys have the anatomy class, like the common carotid artery divides into two, external, internal carotid. Okay, so because of the bifurcation in that region, the calcifications you're going to see. So what is the problem with that? If the patient is having high blood pressure, these calcifications can break down into smaller pieces and cause ischemic stroke. Yes?
On the left side of the mandible, is that a crack? Like a previous broken jaw?
That's exactly what I told. Fracture. Yes. Yeah. You're right. You're absolutely right. Yes. That's a trauma or a fracture. Yes. Okay. That's how you are going to look at the pan. Wow. These are all the things you have to know because I learned already, right? For example, number 33 means
What?
so there is a foramina in the mental region. What do you call it as? Yes, excellent guys. What do you think is this one? 34. There is a gland in the submandibular region and it's a salivary gland. Yes. Okay. What about this 28? Cervical vertebrae, right? How about 20 here? There is a foramina in the incisive region.
Incisive canal.
Yes, also called as nasopalatine foramina. Yes. What do you call this space? This yellow line. It's between palate and tongue.
Space.
Palate and tongue. palatoglossal airspace. And glossopharyngeal is between tongue and the pharynx. If it is extending beyond this, like this. Okay. What do you think is this one?
How are you?
Excellent. See? What about this one? You guys know everything.
What is 11 and 43 pointing to? I don't.
That's the 11 is mid-cranial fossa or middle cranial fossa. Again, here. These are the numbers. Happy reading. Okay? So before we jump into pathology, you should know what is anatomy, what is normal, how it looks on pan, right? That's exactly what we are trying to achieve. Now, you might be thinking, what the hell, so many things we have to learn. Of course, yes. Only if you know what is normal.
There's actually a lot of overlap with another.
Yes, yes, of course, of course. Of course. Don't panic. There's nothing new. You guys know about nasal septum, you guys know about hard palate, you guys know about soft palate. There's nothing new. Like I'm not saying, okay, something like some exorbitant thing which is you guys never heard of. Because anatomy is not going to change, right? What is 17 in this one will represent, the top one? Omer. Okay. How about 39?
How are you?
33.
Mental already.
Okay. How about 23? Conda.
Calm down.
Okay. How about 41?
Palatoglossal airspace.
Hey, stop. If it's black, then if it's air, then yes. What is the extension of hard palate? It looks like, it feels soft, and it's called palate.
Soft palate.
Yes, that's exactly what it is. So this is the hard palate, and the extension of that is the soft palate here.
What did you say 43 was?
43, let's go back. 43, 43, 43. Oh, I didn't say anything, but I'm going to say it. Okay. What is the covering that you are going to see?
Is that anterior to the vertebrae
Yes.
or posterior?
If you're looking from this angle, so this becomes the first, so this is anterior
Okay.
and
Yeah, I see,
posterior.
I see.
Yellow ligament. Yellow ligament.
Yellow ligament.
The size of it?
So,
It's part of pharyngeal wall, and it's located anterior.
Is that the esophagus now?
Anterior pharyngeal wall. Oh. Vocal cords we're not going to see, so that's the anterior pharyngeal wall. That's what you're seeing. Okay, here. What is this? Very important thing.
tongue.
There is huge soft tissue structure in the oral cavity. It starts with letter T, ends with letter E.
Thumb.
That's the lateral part of the tongue. And that's why if you follow here, if the patient is not placing the tongue to the roof of the palate, you are going to see the airspace. Again, you may have, if you looked at the, what do you call it, my, what is that, lecture, Rama, did you look at the PAN, full mouth series? I covered all these things, right? So that means you did not look completely.
It's just not as detailed.
Yeah, of course. That's kind of a little precursor or a pretty basic thing, then you can build on. I can, if I give a lecture of half hour on those little videos, nobody is going to listen. So I made sure that the studies have proven that if it's like 8 to 9 minutes video, then people will generally look at the videos. That's what I try to do. I took a class, how to become a good teacher. So in that, I learned a few things. So here, again, the hard palate here, and this is the ghost image of the hard palate, the top one. So opposite side, and this one is here. Oh, the answers are here, okay. Can't help much. So based on the eruption sequence, you could tell the age of the patient, right? So in this one, the answer is posted already, so 10 to 12 years. So whatever you are seeing, this radiolucent region in the cervical vertebrae is nothing but transverse foramen. And here is the lingula or mandibular foramen, that's what you're seeing. And this is what you're seeing here is the superimposition of these cervical vertebrae. Yes. What caused the white radio-opaque area indicated by red arrow? Dr. Oz.
Thyroid.
Thyroid color, yes. The clue was Dr. Oz, yes. Sometimes you are going to see air cells within the zygomatic arch. That's, please do not think this is any pathology. It's a normal presentation or let's say anatomical variation. Sometimes you could see in certain population groups. So what do you think these arrows are representing to? There is a canal and it lies inferior and it's in the alveolar region. What do you think is this one? Yes. Most commonly you are going to see with the African American people because they tend to put a lot of braids and then they put oil. So if you take a pan, those things, that's how you're going to see on the panoramic radiograph.
I'm sorry, did you say that was hair?
Yes. Or hair with the oil, or braided hair. I don't know much different kinds of braids, all those things, so let's leave it there. Okay, so if you see a discrepancy or radiolucency between two parts of the jaw, like here, you have to think of a fracture or trauma. So this patient, looking at this particular pan, you can see they have placed some hardware here. The arrows that are pointing out are these are the screws that are being projected as a ghost images. So for this particular patient, this is the best pan you could get because unless you take out this hardware, you can never ever get rid of these things. guys. This whole thing. What is the ligament that is coming from the styloid process to the hyoid? Ligament, right? Yes.
Yes.
So sometimes it may be calcified. That's what exactly you're saying. So that's the stylohyoid ligament calcification. So if there is an impacted tooth or erupting molar, this is how you are going to see, depending on how they are erupting into the oral cavity. So this looks like it's coming on the buccals aspect. So here this is more or less coming in the mesial direction. So if it's going to be impacted or fully formed, then we would call this as a mesio-angular impaction. Of course, you're going to learn more during your surgery, the rotations. So if two molars are like this, often called as kissing molars, so these are impacted. So like this one. What do you see in this particular pan? Especially I want you to focus on the right side of the mandible. What do you see here? Only this region. What do you see? Four molars. What do you call that as?
Supernumerary?
Yes. So if it is in the molar region, we would call it as distodens. Or paramolars. Oops. So again, if there is a step-like discrepancy, because it does mimic like a step. So that's the classic sign you would look for fractures. So example of an implant placed, and if you get a pan, this is how it looks like.
Is that a ghost image?
Say one more time. Implant.
Are there two implants though?
Yes, two implants were placed. And if there is a pathology like this. So pan again is a very good imaging modality if you want to look for a broader things or a broader coverage like a pan. Then you would get a pan. Or even for post-surgical, because its radiation is very less and then it's easy to get well tolerated. So post-surgically we would also get pan. Yes, you had a question? No question?
I'm just curious,
Mhm.
where are the ghosts in this implants?
Oh, so it's not in that line, so you're not going to see. It's below the inferior area or border, then you're going to see. Make sense? Only certain areas you're going to see ghost images, not always. So remember I told you, this is very technique sensitive, right? If you misplace the patient's position, then you would see those kinds of things. As I told you, follow-up. Pans are generally recommended. If you want to evaluate any pathology like this one, here, also here there's some pathology, right? Which we are going to talk next semester. What kind of pathology is that? If there is a larger lesions, like here, it is extending from the distal of this molar, third molar, all the way to the ascending ramus. There is a pathology. If you want to evaluate, you could get a pan. Huge lesion here, right? You're not going to miss, right? Okay, one more larger lesion. If it is like a bilaterally, or if the whole of the jaws are involved, then you would also get a pan. So this, where you could see the osteomyelitic reaction happening in this particular patient. I'm not going to ask any pathology this semester. Yeah, next semester you'll be bombarded with questions. Okay. Now, anatomy. For example, where is the condyle located, right? Or soft palate, where is nasopalatal foramen, something like that, along similar lines. Okay. So question everything, right? What do you mean by that? you have teeth here, right? You have a crown portion, you have a root portion. Do you see the same thing here? What happened? What happened there?
He's wearing like a dentist.
Yeah, first your name, please.
Daniela.
Daniela, okay. So the patient is wearing a denture. So dentures, they don't have roots. So that's why for a novice dentist or novice student, they may get confused. We don't ask them to put their dentures when we get a pan. Okay? Any questions with the pan or panoramic imaging modality? We're not done yet. We have 5 more minutes. Sorry, guys. Well, you asked for radiology class, so I'm giving. So what I'm going to do is, let's focus only on this particular slide because of taking into time as a consideration. Please look at these images. What I might be asking you is, on your exam, is to identify what kind of imaging modality is this one, for example. Okay. What structures you could see looking at the anatomy. For example, I'm not going to ask you how you place the patient. So this is a lateral ceph, most commonly used for orthodontic purposes. Okay. So I may ask a question, okay, what kind of imaging modality is that? And then I may ask a question, okay, what structure is this one here? Condyle is here. That's a palate and it's soft. Yes. So something like that, okay? So SM view, this one. This basically is if in good olden days when there was no imaging modalities like CT or CBCT, these imaging modalities they were using. This basically to see if there is any expansion in this region or not. Okay, so patients will be asked to place a check and then they get an X-ray. Now you might be asking why the hell I'm covering, right? This one, although we don't use extensively these days for your boards, they will ask you. So that's why I have to cover it. If you ask me, even I don't like to cover this one, just for your boards. So this is Waters view. The way I would remember this as Waters view is like a W. If you write letter W, like here, this is the mandible, sorry, something like that. It's a Waters view. Basically, you are going to evaluate all the sinuses, like 4 sinuses. How many, can you name those sinuses? Sam, next to you.
Next to me.
4 sinuses. No? Okay. The way I would remember, like, I don't know, you guys are familiar with the gems, those small things like M&M things? Okay. Right? So I would remember as FEMS, F-E-M-S. So frontal, ethmoidal, maxillary, and sphenoid sinus. For paranasal sinus. F-E-M-S. Maybe in our country we used to get pretty similar to M&M, it's like the small little things. They used to be called as GEMS, G-E-M-S. I don't know if it's available here. Yes?
Could you repeat those?
Oh, frontal, ethmoidal, maxillary, and sphenoid. The way I would remember as FEMS, F-E-M-S. So basically, Waters view is used to evaluate the sinuses, all the 4 paranasal glands. So here, PA of set. So depending on the area that you are trying to capture, it could be PA of skull or PA of the mandible. So basically you look at the evaluation of the mandible or condyles, and then what we have here is the lateral border of the mandible here. So especially for 3rd molar impactions. Also here, the other thing is the ramus, if you want to check our pathology, they used to get this oblique lateral view. So some questions may be popping up, for instance, Waters view. I told you the way I would remember is like W, huge. So basically, you are looking at maxillary sinuses, or all the 4 sinuses. Sorry, and the anatomy. Please review the anatomy. We talked about a pan. What else? Transcranial, no. Transpharyngeal, no. I'm going to cover a little bit on CT imaging. Like I've got a couple more slides, I think. More. I'll stop here. That's okay. We'll. Yes.
Do you want us to like know the numbers too?
Numbers. What do you mean by that? What kind of numbers? You have to be more specific. Oh, no, absolutely no. Those are your guidelines. Every office is different, so no.
What about physics behind it?
Yes, of course. I spent like many number of hours and you're asking the question.
I know, but you emphasize these things.
Well, there will be few questions from there. Yes. So basically, okay, so I did not go into the detail of a reverse storm taking into time as a consideration, but I might cover next time. Don't worry, not for the midterm exam. I'll make sure that whatever is covered will be on your exam, if that's going to help you. Okay. Any questions? No questions.